Yeah. So this was this is a full thickness retinal fold. So I did a buckle for this superior bullous hardy for these reasons best known to me. However, first post-op day, that's what the patient had. As a full thickness retinal fold with photoreceptor to photoreceptor orientation, and 2 weeks later didn't respond. So I took the patient up for surgery, did a standard 25 gauge, and you can see there are actually 2 folds. One is there. So the problem was twofold because I had 2 folds, if I can say that. And that was the buccal height. That was the localized hemorrhage that I had had in the subretinal space during drainage. That was the, that linear line passing from the disc through the fovea out to the temporal periphery was the area of concern. So I used, trypan blue dye, stained the ILM because the internal limiting membrane, the ILM, is what acts as like a memory or a skeleton for the entire retinal structure, and it's responsible for about 50% of the compliance of the retina. So if you want the retina to become more compliant, it has to come off. So I peeled it off, after peeling it off regularly as I did, put in the 4th port for the chandelier so that both my hands were free, had a 38 gauge subretinal med1 cannula with balanced salt solution. And as you would do to induce a retinal detachment in macular translocation cases, that's what I did. I actually infused some fluid within the macula, but of course extrafoveally, because the idea is you do not want to inject directly into the fold. You want to inject far away and let the fluid in the subretinal space gradually go and open the fold as it did there. And once that was done, my fold opened on table. I did a fluid air exchange, and ensured that all of the subretinal BSS was compressed by the air posteriorly. So I had a big blob in the middle at the end of surgery, and finished this patient with SF6. As you can see, that's that kind of if I can say, a pomfret shaped appearance at the end of surgery. And I just gave this patient SF6 face down position, and had the patient position prone. The patient did fairly well. The fold went away with anything. This is another patient, quick video, different scenario, not post buckling. This was post foreign body removal, and the patient had oil in situ. I had removed the ILM, mind you, in the first case, as you'll soon see. So but this patient still had a fold. I did my VFC assisted SOR. I had to convert to a 23 gauge because the subretinal cannula I had that day was only this. And you can see that the ILM is already peeled, but I went in and again injected subretinal BSS. Again, not directly into the fold. You want to be intramacular, but extrafoveal, obviously, and let the fluid passively come in. And that was that. That's what created that bleb. That temporal laser is the trauma from the foreign body. And as you'll soon see at the end, I again finished with gas and gave the patient prone. That's what the patient had. You saw the fold at the end, and we had a good foveal contour at the end. So that's how you would deal with retinal folds. Thank you.